Welcome to the Mindset Matters, the podcast where psychiatry, medicine, and real human experiences collide, all through the eyes of two psychiatric PAs.
We're your hosts, PA Mercedes Dodge and PA Jessica Spissinger, two passionate psych PAs on a mission to bridge the gap in mental health care.
So whether you're a provider just here to level up your psychiatric insight, increase your mental health skills, you're in the right place.
Each episode, we shine a light on the incredible work PAs are doing in psychiatry and beyond. Our goal is to build a community focused on better patient care, professional growth, and personal well-being.
This podcast, a little disclaimer, is for educational purposes only. We're not here offering medical advice, psychiatric advice. If you or someone you know needs support, please reach out to a licensed mental health professional. All right, guys, let's dive in.
All right, so we're back again for another mini mindset. And yet again, I'm going to dive into the psychopharm lens. And as we have an interview coming up with Sarah Totko, I'm going to spotlight ketamine because we're going to be talking a lot about that in her interview. Are you excited?
I think I hear a lot more about this treatment in the news. And so I really like diving into some of the evidence, like the real stuff a new clinician should know.
It's been really interesting. I'm glad I had a chance to look into it more because there's a lot of ketamine research being done and clinical options out there. So guess where we're going to start?
The history. I love
the history. All about the golden age of psychopharm. And we haven't gone yet into the antipsychotics. I've got a little shot here from an old Thorazine ad. And now we're going to go into the age of the psychonaut. So now we're actually going to talk about the 1960s, which you could call the age of the psychonaut. Have you ever heard that term?
I think I have a couple times, but I don't use that word. So educate us.
I know. Think about astronaut, right? Psyche, of course, being the Greek derivative of soul, spirit, mind. So instead of exploring space, we're exploring the psyche. In the 1960s, this was the pinnacle of psychiatric psychedelic experimentation. All right, so we're going to talk about ketamine. You may or may not have known this, but it's compared to some of the other medications, a little newer. It was formulated in the 60s by this guy named Calvin Stevens. He was chemistry professor at Wayne State and also foot in the door with the pharmaceutical company, Park Davis. They were after, at the time, we talked about the other medications deriving from the search for anesthesia. They still were looking for this perfect anesthesia. They had most recently come up with phencyclidine or PCP. PCP is also very commonly known for very aggressive, active behavior attributed to a lot of behavioral issues. They kept looking for something else. And so with ketamine, it was a cyclohexanone derived, and cyclohexanone is an organic compound, which is essentially a 6-carbon cyclic molecule. I love to go into the basic chemistry here. It's a colorless, oily liquid with a sweet odor that yellows over time. Yum, yum. And what's interesting is cyclohexanone actually winds up creating nylons and pantyhose. So ketamine, pantyhose, those were the two different directions it could go. As this was the 1960s and no one ever heard about ethical research trials, they experimented on animals, which we continue to do, but they also experimented on human prisoners because, hey, we got all these people sitting around. Let's give it to them and see what happens. They noted in this process was that ketamine had a very rapid effect, but that on the positive end, the patients were able to maintain cardiovascular stability. Their airways remained open. So they said, okay, great. We've got this thing. Let's start using it. And what it was called in their first use was with the Vietnam soldiers was battlefield anesthesia. They brought it right out onto the ground in the middle of the Vietnam War to provide anesthesia needed for on-the-ground surgical procedures. They also gave it as a cat tranquilizer in veterinary medicine. One of the researchers wanted to call it dreaming, but actually one of the wives of the pharmacologist said, how about call it a dissociative amnesia? Because they were noticing this kind of detached effect that people were having. So it didn't take too long before it went from the clinical laboratory experimental trials on the field and in veterinarian offices to being distributed on the streets. I tried to look into that and I'm like, how did it go from this academic research lab onto the West Coast streets? It seems as though researchers are curious. So in addition to doing their studies, they may also be like, hey, let's see what happens depending on how much was used. In addition to the anesthesia effect, some people were feeling some euphoria and relaxation and this dreamy, floaty sensation. And people were like, hey, this is actually kind of, a friend of a friend of a friend. I was all trying it out. And the next thing you know, pathways are open. So it really became pretty rampantly abused by the end of the 1970s. Usually the crystal formulation at the time was snorted. And this continued into the 1980s and the rave culture, where it became a very popular party drug. So we're just going to touch upon some of the popular culture that sprang out of this. There's a couple big figures in the ketamine exploration that happened in the 1970s. This one guy, John Lilly, wrote this book, The Scientist, and he was one of the self-identified psychonauts. And he coined this term that ketamine is a peeping Tom at the keyhole of eternity. And I'm like, that is just the best quote. And he was as a physician and neuroscientist, then became psychoanalyst and philosopher, you name it. He was into it. So he was doing his thing. Then Marsha Moore, she was from Cambridge, a yoga teacher, and she got really interested in the mind-altering properties of ketamine as well. She wrote this book, Into the Bright World, and a couple others. Additionally, there was this kind of interesting book. It was called The Fabulous Furry Freak Brothers. It was a comic from the 70s, and they had a lot of ketamine references in there. So that was kind of ketamine's heyday as far as psychedelic experimentation in the 70s. Here, of course, there's been at least one very famous fatality, Matthew Perry dying actually about exactly 2 years ago. It was October 28th in 2023. There was this other guy who's probably not as well known. His name is D.M. Turner, and he wrote this book called The Essential Psychedelic Guide. He was in that 70s experimental culture. But what's interesting is that both of them wound up dying as a result of ketamine, and both in a circumstance where they became unconscious and drowned in bathtubs. Perry, of course, was a hot tub, but Turner was in his own bathtub. So it just really highlights that while this is, a chemical that has been abused because it can be fun, it also can be dangerous if used incorrectly. So ketamine, street party drug. Do you know any slang names that it goes by?
Yes, I do remember that. Is it vitamin K or special K? The main ones.
Same for me. That's what I knew. But apparently there's actually so many others. Mean Green, Rock, Max, Special K, as you said. Calvin, I like that because you remember the originator was Calvin. So shout out to Calvin. Mauve, Purple, Psychonil, Special LA Coke is another one. Cat Valium, Kelly's Day, K2. A lot of really interesting variations. Way more than is even listed here. What about the word on the shelf? How many brand names of ketamine do you know?
I think that's the only
Spravato.
one that, it's a nasal spray. And that came out while I was practicing medicine.
Same girl. Like it's ketamine or it's esketamine Spravato. But apparently there's actually a whole bunch of other brands that it goes by. Esketamine is not only Spravato, but it can also be called Kentanest. All of these other names refer to just basic racemic ketamine, Calypso, ketamine, ketamina. That's how you say it. So just interesting. I always like to find these funny factoids. Certainly, those are not words that we're too familiar with. Okay, so I've had my fun. Thank you for indulging me. I'm now going to dive into the basics. We're going to talk about the pivot point from how ketamine became useful in psychiatric treatment. And this was really like a turn of into the 2000s that the research began. And it's been considered a game changer in the world of antidepressants because other than the serotonergic agents and the use of atypical antipsychotics, we haven't had any new formulations. Spravato was approved by the FDA in 2019 with the indication for treatment-resistant depression in combination with an oral antidepressant. It was expanded a little over a year later where it was included major depression when there's acute suicidal ideation. And like I said, this really marked a big paradigm shift, not only because it's a new formulation, but because it had this rapid action, which we'll talk about a bit more, where people notice an effect in hours versus weeks. Do you know anything about the difference between ketamine versus esketamine?
I would probably say the distribution of how it's metabolized of some sort.
Well, we're going to go into that. And we've got lots of myths. Tell me what you think is true or not. Probably the first one, you know the answer. Ketamine is just a party drug.
No, it's not. That's false.
Works the same as SSRIs?
I would say no, because this is a breakthrough and it doesn't work on the regular ways that SSRIs work. And then the third one is ketamine therapy is unregulated. I struggle with this because I hear people doing ketamine therapy without strict guidelines. So it is unregulated. I'd like to learn more about logistics of how to practice with ketamine. The fourth one is ketamine causes brain damage. I say no. And then the fifth one is ketamine is addictive. I do think that is true.
Okay, so we'll circle back to these and go from there. We'll reveal them towards the end. All right, so I'm going to go through psychopharm basics. And here I'm going to talk about the difference. So there are two different kinds of ketamine. Sometimes we say ketamine and we mean ketamine plus esketamine. But the differentiation is that oftentimes when people say ketamine, they're actually referring to racemic ketamine. And so we'll try to clarify that going forward. And the primary difference between the two is on a molecular level, where the spatial orientation of the atoms is around one different chiral center. That's called the stereochemistry. The functional difference is that the esketamine is just one chiral variation of the ketamine. And that one happens to bind more tightly to the MDMA, so it produces a stronger effect on that end. A little bit of review of the chemistry. An example of that would be like venlafaxine and desvenlafaxine. So we've got our esketamine and racemic ketamine. It's a mix of both, like a 1-to-1 ratio of R-ketamine and esketamine. And then the esketamine is just the esketamine. So we just ditched the R-ketamine to come up with the formulation that's in Spravato, but otherwise the same chemical compounds. And when we're talking about just blanket overall, both formulations act primarily as non-competitive MDMA receptor antagonists. NDMA, again, is that N-methyl deaspirate. And they block the receptor, which reduces the excitatory neurotransmission, increasing glutamate release and stimulating synaptic plasticity. I was digging in a bit deeper and I was like, I'm just going to kind of really stick to the key points here. But you want to remember with ketamine that it's a different mechanism, and that it's being an antagonist on the NDMA receptor. These are primarily glutaminergic receptors, and it's modulating a lot of different pathways, including AMPA, which is alpha amino 3 hydroxyl methyl 4 isozolomproanoic acid, also modulates and enhances BDNF. You're familiar with BDNF, right?
Yeah, BDNF is the thing that we're talking about a lot. Like when I was doing the deep dive on exercise and then also in nutrition, like there's areas where we can modify the release of BDNF. So it's really interesting.
It's kind of considered like a fertilizer for the brain. If you do weightlifting, it's like promoting your BDNF. So it's the good stuff we want. This is where it's enhancing that synaptic plasticity, which means that it's giving our synapses more chances for connection and growth, which is very desirable when we're wanting to create change psychiatrically. So here's a little table breakdown to reference about the different pathways. If you want to look into it further, I'm just going to jump ahead to our clinical uses and applications. I put this table together to reaffirm when we're talking about racemic ketamine versus esketamine. They're different configurations. And the affinity for the MDMA receptor binding is 3 to 4 times higher with the just single esketamine form. That makes it more potent. It actually makes the psychoactive dissociative elements a little bit lower at equal doses because the R-ketamine really activates that psychoactive element as well. When you look at the bioavailability, esketamine only comes in the intranasal form, and that ability is about 25 to 50%, much lower than what we see with the IV and IM, which is like 100 to 90. And as you can see, orally, PO, it's much lower. It confused me for a while because I'm like, I kind of thought all ketamine was the same, but I understand that racemic ketamine is like a picture IV infusions. You hear about these very expensive like wellness clinics that have popped up. Of course, this is the route that Matthew Perry went. And so the bottom line is with racemic ketamine, it's still off-label for depression, PTSD, anxiety. The typical setting is more of that boutique private clinic psychiatry office versus Spravato, which is FDA approved for those two different indications. And that can only be administered in a REMS certified medical center. And we'll talk a bit more about that too. So again, the racemic ketamine is going to generally be IM, IV infusion, and it may be administered, this is kind of an example protocol where it's going to be 1 to 2 times weekly, 4 to 6 sessions, often with psychiatric and medical supervision. There is some monitoring required because of the anesthetic effect, and it can elevate the person's blood pressure. So making sure that their cardiovascular and vitals are stable and monitoring their mental status and dissociative state. Usually about an hour post-infusion, observation is required, and then they can go. But there are some changing protocols. So this isn't always fixed. Versus the Spravato, again, FDA approved, and with those, the REMS clinical, which is risk evaluation mitigation strategies, just like Accutane, things like that. It has to be administered in this clinic that has the REMS certification of the facility standards. Here, it's essentially 2 hours post-dose required for monitoring.
And it's the same monitoring for the racemic?
So I think that's where it's like a moving target because I've seen different numbers. The number I quoted for the IV was about 1 hour, and here it says about 2 hours. The REMS is more regimented based on the fact that it's a REMS clinic. which is requiring about 2 hours, is what I've read. And they can't drive until the next day versus the IV clinics because it's off label. So there's kind of a bit more nebulous use.
I see.
And then for the esketamine, it seems like here's an example of some durations. I have a patient who's been taking it and it looked a little different, but there tends to be more of this intensive administration at the beginning, doing it about twice weekly for 4 weeks, then weekly 1 to 2 weeks, and twice weekly based on the indication for 4 weeks. However, it does seem to be the case that there's really no endpoint. And for patients that discontinue, they decompensate, then they go into a maintenance, which is about every week to every other week. That's the question, right? Because while there's a lot of research, most of the research has been based on short-term clinical trials. And we're really only a couple, like 5 years in since Spravato's been FDA approved. So we're going to learn a lot more as we go forward. There are some safety and contraindications to be mindful of. So if you're a provider and you've got a patient who's interested and, thinking about referrals, if they have a history of like uncontrolled hypertension, if they have like intracranial vascular diseases with aneurysms, history of psychosis, schizophrenia, again, really severe cardiovascular disease, if they're pregnant, and also if there's active substance abuse disorder, probably going to want to avoid or use very cautiously. Very common adverse effects across the board is obviously dissociation, but with that can come some dizziness, perceptual changes, which can include more hallucinations. Hypertension, as I mentioned, is a big part of it. Nausea is really common as well, kind of tied up with the dizziness people experience. Laryngospasm, emerging delirium is more rare, but can occur. My biggest question going into this was concern about the drug interactions. I'm just skimming the surface here, so I'd recommend everyone do their due diligence, but I'm going to run through some of the basics. Essentially, with someone who's on like a CNS depressant, which includes like benzos, opioids, you always think about that additive CNS effect. That's pretty typical that we see. But it does seem, in fact, that can actually reduce the positive antidepressant effects. So if someone's on a chronic benzo and they're getting ketamine, they might not get the full efficacy of the ketamine. The recommendation is to try to avoid benzos unless they're needed for acute stabilization. Our usual friends, the serotonergic agents, there's no absolute contraindication. A lot of the Spravato is FDA approved for use with the oral antidepressant. Of course, not our MAOIs, because we know we're not going to be having those anywhere near. It is possible that they can increase the hypertensive response. And of course, with MAOIs, we know there's always that risk for hypertensive crisis. Antipsychotics generally can be taken, but again, it's an antipsychotic and this is a psychedelic. So it's kind of opposing the initial element. If somebody's taking an antipsychotic as an adjunctive depressive agent, it may actually still interfere and kind of blunt the ketamine effect. And again, I'm speaking from my takes here. Other people may have found different research, but based on what I found, this is my conclusions. Sympathomedic, so we're thinking like stimulants, hypertensives. We're already concerned with hypertensive effect from ketamine. So if you already have another medication, such as a stimulant, that may have a concerning impact on the blood pressure. Lithium, lamotrigine, valproate, our mood stabilizers all have a different impact. Lithium can make the dissociation and sedation more pronounced. Lamotrigine may actually reduce the glutamate release, so that could also dampen the antidepressant effect. And valproate may just make them a bit more sleepy. With regard to substances, it's that additive CNS effect with alcohol. Bottom line here with alcohol is that it can alter MDMA receptor sensitivity, and that can lead to an unpredictable response. So we want to make sure our patients are being forthcoming with what they're taking. And again, the cardiovascular interaction, just remembering that it's increasing heart rate plus myocardial oxygen demand. So if the patient is on like a beta blocker or clonidine for some anxiety, some of that ketamine hypertensive impact, they could actually have a post-infusion hypotensive effect. So it may be like keeps the hypertension effect in check, but then once the ketamine's gone, their blood pressure could actually bottom out a bit more. All right, so here's my little summary slide, but I believe Serotoxico has probably an even better one to go through with some of the drug interactions. And that's always our primary concern if we're not working in a field where we're really having a lot of expertise on ketamine, but have patients that might be interested or on it, that we know what's in the picture. All right, so getting close to wrapping up, just want to make a few words on the special sauce, which is psychotherapy combined with ketamine. Not everybody does this, but combining the pharmacologic neuroplasticity that ketamine can produce with psychological processing really can lead to the optimal effect. Just like with any medication, ketamine is not a cure, it's a catalyst. I found this quote, I couldn't find who said it, but medication opens the door, psychotherapy walks the patient through it. I really love that. And I think that with ketamine, it seems like there's a great opportunity in this neuroplastic window, which can be hours to days, where this enhanced openness, emotional flexibility, and insight is their path of exploration than they had in the past. And there's evidence that shows improvement, like reduced relapse rates, more of a durable antidepressant effect when the psychotherapy is interwoven. It usually goes through this framework where there's a lot of preparation psychologically prior to the treatment, making sure the patient feels safe and comfortable. Then during the session, the provider's going to be making sure that they're maintaining a presence, but not intrusive. Then the post-session is going to be a guided debrief, reflections, journaling if needed. This is where core techniques could be introduced. And then it'll be the ongoing maintenance to repeat the process and build that relationship. It's a lot of research that supports integration. I put a lot of these studies towards the end. It does seem that a lot of different types are introduced and very effective. It's not like one type has been shown to be better than another. So lots of questions remain, like further research. It'd be helpful to know like if there are more definitive outcomes in terms of the processes. But so much with therapy, it doesn't always matter the technique. It's about that safe provider-patient relationship. One other thing I stumbled upon is that new research just came out in 2025, and it's a study on esketamine monotherapy for treatment-resistant depression. So forget the oral antidepressants, just straight up esketamine. How does it do? They did this study with about 378 participants with different doses. It was a 4-week clinical trial with a 12-week optional extension. The conclusion was that it did actually work. It found that both doses were very effective, very well tolerated. So this could be down the pike that eventually the indication drops that oral antidepressant. There are concerns and limitations with all studies that you should be mindful of. One is that the study was conducted and funded by Janssen, the Spravato manufacturer. There could be some limited generalizability. Anyone who has psychotic disorders, bipolar, active suicidality, substance use, or screened out. The demographic is pretty narrow, predominantly white, so there's limited racial and ethnic representation. Just done in the US, so a lot of cross-culture question for the applicability. Again, that short-term duration was only 4 weeks. And while there was this open label phase, there was no control group then. So you really couldn't compare.
And also the fact that while there was like these 2 different doses in the placebo group is going to know that they're not dissociating. So they may kind of know what's up. Those who are getting are
it's probably not possible to not notice the effects. Interesting. I'm going to leave you some practice guidelines. Spravato has a find a provider directory on their webpage, so you can do a little search by zip code. If you're interested in the racemic ketamine, the IV, IM, again, this is a little bit less regulated. For anyone who wants to go this route as a provider, they actually have to have a DEA license for Schedule 3 drugs. There are provider directories at the American Society of Ketamine Physicians, Psychotherapists, and Practitioners. And a lot of university and affiliates will have programs. And there is this kind of ketamine clinic directory as well. If you as a PA want to open a ketamine clinic, you have to decide which pathway you want to go down. And if it's going to be racemic ketamine versus esketamine, different process involved. So I've got this here for your reference. And a practice checklist and resources. So we are at our time. How do you think we did with our debunking? Let's check. Well, we already answered the first 2. You already said you were right. It's not just a party drug. We know it has a different pathway, being an antagonist of the MDMA receptor. Ketamine therapy is unregulated. What are your thoughts now?
Well, now, because the racemic is pretty much unregulated and the Spravato is regulated. So that was the trick question.
But I will say, no, you still have to have like the DEA Schedule 3 to prescribe the compounded racemic ketamine. So regulated on that end.
You're right.
Does it cause
brain damage?
I did not. But I think it's fair to say, given that it's been since the 60s and the 70s when everyone was like, let's do ketamine all the time. There is toxicity and fatality with overdose, but there has not seemed to be any long-term concerns about any kind of evidence that it causes neurotoxicity in humans.
Yeah, I think you're right. No evidence about the brain damage when it comes to harm. Can someone with ketamine die? And I think the answer is yes, especially if there's several other substances on board. And I think that's where the trick part, like you mentioned, Matthew Perry, there's been a lot of individuals using that along with other substances. So in the end, I still feel like ketamine can be addictive. Habit, I think that if just when we used it in the Ray world, people liked that feeling and that release. And so I think it's even more dangerous now where a lot of people have mental health conditions. That's their coping mechanism, possibly their pathway to release. But if you're not having the psychotherapy on board, it can lead to maladaptive behavior.
Yeah, I think that's fair to say.
I think that this was a great talk, Jessica. I liked that you summarized it. You went over the research and you went over like kind of the dilemmas that we run to as a clinician. And also like when we're trying to talk to other clinicians about the use of it, one, we have to know the history. And then you also need to understand how it doesn't work on serotonin like SSRIs, right? Because it works more on the glutamate. My takeaway is that it's complicated. This may work for someone and it might not work for another.
Yeah.
What I love about our podcast with Sarah Tetko is that she walks us through how it is in practice as a clinician and how to do it with psychotherapy involved. It's constantly like keeps me curious about learning more because, you know, this is just since Spravato since 2019. We're still looking at the long-term data. If we're doing this in 20 years, we'll be sharing a different tune.
Absolutely. It's always fun to be here.
All right. Thank you guys for joining.